Good afternoon, everyone. When we think of menopause, in fact, my talk is probably going to be a little bit of repetition, and I totally agree with Dr. Meenakshi. This is a very light topic after the various workshops on MHT and all. But when we think of menopause, we often focus on bone health, hot flashes, or cardiovascular risks. But one of the most visible and emotionally impactful changes happens right in front of us, the skin. So menopausal hormonal changes are frequently dismissed as cosmetic or age-related. However, as gynecologists, we understand that these are hormonally driven, especially because of the sharp decline in the circulating estrogen levels. And they significantly impact the comfort, confidence, and the quality of life of a woman. So skin is not just a surface organ, it is hormonally responsive, and menopausal changes or menopausal hormonal changes alters its structure and function in measurable ways. So today, from a gynecologist's perspective, I'd like to explore how hormonal changes impact the skin at menopause, review the clinical evidence behind these changes, and most importantly, discuss the collaborative approach between a dermatologist and a gynecologist so as to give best outcomes to our patients. Let us begin with the quick physiology. Some of it has already been discussed by Dr. Meenakshi. The estrogen, I would like to, impress upon everyone here that estrogen receptors are present in epidermis, dermis, fibroblasts, sebaceous glands, and even the hair follicles. And with the sharp decline in the estrogen levels, especially the 17-beta estradiol levels, of course, the function of all these target organs declines. So, therefore, with this drastic decline in the estrogen levels, there is less amount of collagen produced, which is a major fibrous tissue component of the dermis. And this fibrous tissue is mainly comprised of collagen, which is produced by fibroblasts. So fibroblasts have estrogen receptors. Therefore, when the estrogen is not there, these fibroblasts are not producing enough of collagen, and there is loss of dermal thickness, loss of elasticity, there is less of sebum production, dryness of skin, and the loss of elasticity and barrier function of the skin. Of course, therefore, estrogen matters. This has already been spoken about by Dr. Meenakshi. So the important point which I would like to stress here is that there is an early critical window which is within the first 5 years of menopause. That is the majority, 30% of the dermal collagen is lost in the first 5 years of menopause, and thereafter the average decline is only 2.1% per year. The estrogen is known to increase collagen synthesis, maintain the dermal thickness, maintain the elasticity of the skin, maintain hydration via glycosaminoglycans and ceramides, produce enough of sebum, and maintain a skin barrier function. Whereas as the estrogen is lost, all these functions decline and there is accelerated aging-like changes visible in the perimenopausal period. This is a graph showing dermal collagen versus years since menopause, illustrating rapid decline in the first 5 years. So this is the early critical window, impressing upon all of us as gynecologists that this is the time period when the intervention should begin. And thereafter, the decline is slower. So the dermatologist and the gynecologist have to act upon during these early postmenopausal years to prevent the skin changes. Now, what are the key skin changes seen at menopause? Clinically, women present with thinning of skin, increased wrinkling, dryness, pruritus in the form of your uh, xerosis, delayed wound healing, easy bruising. And many of these patients, they keep cycling between, clinics without connecting these symptoms to menopause. Recognizing these as hypoestrogenic changes allows for better counseling and timely referrals between gynecology and dermatology. There is at least one-third of women, they present with frontal hair loss and hyperpigmentation as a result of relatively increase in the circulating androgen levels. And of course, these are not just cosmetic changes, they influence the self-image and comfort level of a woman. Survey has shown that there is high prevalence of symptoms like xerosis and sagging in the menopause clinics. In fact, most of the patients, they present with xerosis and sagging and often are ignored by we as gynecologists. So here we have to relate all these changes to the hypoestrogenic status, and maybe they need timely referrals to the dermatologist as well. So what are the common skin conditions seen? Just to, briefly mention them here, I have used this slide. We know atrophic vulvovaginitis is a very common symptom. Then dryness of skin, etc. I've already mentioned. Vaginitis, which can have multiple causes. Vulvar lichen sclerosis is one entity which is actually chronic atrophic anogenital disease marked with itching and irritation, white and thinned out wrinkled skin. Vulvodynia, hirsutism, often in this period, women present with increased facial hair growth, alopecia, menopausal flushing, which is seen in 70 to 85% of women. This again is because of the estrogen receptors present in the skin. Then keratoderma, climatricum, which is thickened palms and soles associated with painful cracking of the skin. Of course, therefore, estrogen has a beneficial effect both on the epidermis and the dermis, as the estrogen receptors are present in both these layers. Evidence from clinical studies shows that estrogen therapy improves dermal thickness compared to placebo, and estrogen enhances collagen synthesis, increases hydration, and improves the elasticity of the skin. This is the placebo versus the estrogen dermal thickness graph showing the placebo baseline, and almost 30% relative increase in the dermal thickness is noticed with estrogen therapy. Therefore, estrogen definitely helps in maintaining the skin health in the immediate post-menopausal period. So it is the most beneficial effects are noticed if the patient receives therapy in the early post-menopausal period of her menopause. Now, these are the salient features of the MHT on the skin. However, it is important to note that there are relatively few clinical trials which are specific to skin outcomes. It has been seen that short-term MHT fails to bring marked improvements in the skin, and maximum prevention of skin aging following MHT occurs during perimenopause, as I just mentioned. Role of phytoestrogens is not yet established, and of course, the response varies from individual to individual. As we just heard, that genes, various other factors like the skin exposure of the patient and her basic nutritional status all determine how good does she respond to the therapies. Now here I would like to mention the decision to start with MHT must always be individualized based on overall symptom burden, the cardiovascular and breast risk and patient preference. However, the current guidelines do not recommend prescribing MHT solely for skin indication. Therefore, initiation of MHT just for cosmetic indication is not recommended. So this is an important message here. Many women would come only with these symptoms that I am also, they would come with some gynecological problem and would happen to mention that, can you give me something for this? So you need to, take a detailed history. If she fits into the criteria of MHT, then only prescribe. Per se, because of her skin changes, we are not supposed to start her on MHT. Now coming down to the non-hormonal and the adjunctive approaches, which is actually the domain of the dermatologist. So from a dermatology standpoint on hormonal, non-hormonal strategies in the form of various non-invasive and invasive techniques, these remain foundational. These include barrier gentle repair moisturizers, ceramides, hyaluronic acid, sunscreens, and various nutraceuticals in the form of antioxidants, omega-3 fatty acids. Emerging therapies include topical serums and phytoestrogens. They have shown promising results in the initial clinical researches. However, these therapies are still evolving. These interventions might prove especially useful for women who cannot choose or choose not to use systemic hormones. So here comes the role of a dermatologist. So I'm sure they are going to have beautiful session on non-invasive, and I'm not going to, this was just to mention here the non-hormonal approaches. Now, to conclude, menopausal skin changes are hormonally driven and clinically significant. Yes, I'm finishing. This is my last slide. Early post-menopause is the critical window wherein the intervention should begin. And hormone therapy can improve skin health but must be individualized. The current guidelines do not recommend the use of MHT solely for the cosmetic reason. And most importantly, a collaborative approach between gynecologists and dermatologists ensures better outcomes for women. Thank you very much.
Thank you, madam. Thank you very much. That was a lucid talk. Thank you.